I'm delighted to welcome you to our panel this morning on empowering CBOs to address social need gaps. We're here to discuss an ambitious goal, which is creating a robust, integrated system of care that does not just address medical needs, but the underlying social factors that impact health. And the 1115 waivers, mentioned a few times, is a crucial tool in this effort, particularly in its support in creating the social care networks, and also the Health Equity Regional Organization, HERO, in New York, which is really setting up the infrastructure to better resource CBOs, facilitate cross-sector collaboration between health plans, providers, social services, and ultimately impact health outcomes. So our expert panelists today will share their experiences from the front lines of this transformation, and they will offer insights into how social care networks are helping to resource CBOs, foster this cross-sector collaboration, and drive to outcomes. So let me introduce our panel, Dr. Oxiris Barbot, who is President and CEO of the United Hospital Fund, Caroline Heindrichs, Strategic Initiatives Director at Anthem Blue Cross Blue Shield New York, Amie Parikh, who is CEO of Hudson Valley Care Coalition, and Zach Hennessey, who is Chief Strategy Officer at Public Health Solutions. So my first question for each of the panelists, and we can just go down the line, is the fact that the 1115 waiver has a major focus on establishing the social care networks and the infrastructure to better connect CBOs to healthcare and to patients. How is this going from each of your vantage points, and what do you think New York will look like in the near future?
Thanks so much. It's a pleasure to be here, and thank you for the warm welcome. Public Health Solutions is the largest public health nonprofit in New York City, and we come at this from a very unique perspective. We work at the intersection of public health, healthcare, and social services, and our mission is really to close the gaps that we see across New York City in life expectancy and other health outcomes. So just by way of example, in East Harlem, you have 10 years less of life on average than if you just step south of 110th Street into the Upper East Side, where life expectancy is 10 years higher. So we have considerable ways to go on health inequities in our city, and Public Health Solutions exists to change that trajectory and close those gaps. WholeYouNYC is our social care network. It includes over 100 organizations collaborating in real time on a single technology platform and being paid for the first time through the Medicaid program to deliver food, transportation, and housing support at critical moments in a Medicaid member's health journey. Things like remediating mold in an apartment where there's a child with asthma. Think how many times that child has been to the emergency room when you could just fix the mold. Medically tailored meals for people living with diabetes. When you provide some of these targeted services, it frees people up to better engage in preventive care, manage their chronic conditions, and avoid unnecessary acute care use like turning to the emergency department or the hospital for care. And that is incredibly powerful and what we are trying to bring to scale. And it's an incredibly powerful healthcare transformation, but it's also an incredibly powerful public health priority. And so as a social care network, what we're really focused on is successfully weaving together resources from Medicaid, but also from government, and also from social services and philanthropy, to create a single infrastructure for the delivery of social care in New York City. And we represent 2.6 million Medicaid members in Queens, Brooklyn, and Manhattan. And I'm excited to say that we have already provided or awarded $7 million in capacity building funds for our community-based organizations to get up and running. We've trained over 2,000 social care navigators on our technology platform. We have screened over 4,000 members, 3,000 of whom have a unmet health-related social need. We have made over 12,000 referrals and are actively providing the new Medicaid-funded health-related social needs services to over 1,000 members, and that's just in our first quarter of activity. So we've got a long way to go. And where I see this going is, despite the challenges and the pace of this waiver and its potential end date in 2027, I see us being able to show some critical impacts within what the state has defined as these enhanced populations, people returning from prison and jail, people living with substance use or mental health conditions. Being able to show how these enhanced services that we're providing has impacted people on Medicaid who belong to one of those categories in a way that is incredibly valuable to our health plan partners, to our public health system, and to our healthcare system.
So I'll take a different view on this. So what I found really creative that New York State did, because if you look at the other 1115 waivers that have been implemented across the state, New York really thought about regional diversity and allowing our regions to create networks that would thrive and sustain in that region. So in the Hudson Valley region, we started our journey back in 2022, really a whole person approach. We are a lead health home in the Hudson Valley. We are a behavioral health independent practice association, and then we became the social care network. So our vision is really whole person care. And the credit really goes to creating these hubs, right? So if you think about a hub, and if you think about the resources that community-based organizations do not have, they don't have the resources to build up their revenue cycle management. They don't have the resources to bill. They don't have the resources to do technical assistance and training. And that is our responsibility as a lead in the Hudson Valley, in New York, in Capital Region, in Western Region, and Long Island. I don't want to leave Long Island out. And I think that that was very innovative and creative, that the CBOs can have a direct connect to their lead agency and get that assistance and get that capacity built for the people in their surrounding communities. And the community-based organizations are the organizations that the marginalized communities turn to, right? They won't turn to the lead, they'll turn to like Access Supports for Living that is across the Hudson Valley, or Greater Mental Health of New York, which is located in Westchester, or Honor, which is a small community-based organization that provides housing and food and shelter, right? And so where I was really, really excited and inspired and motivated is that we can turn our own communities together and we can create our own ecosystems and collaboration and do co-design. And that's what New York State left up to the lead organizations to do. In the Hudson Valley, we have over 100 organizations. We have 7 counties, Department of Health, Department of Mental Health, Department of Social Services, all coming together to create this ecosystem. We have 100% support from our hospital systems. They don't know how they're gonna participate, but they're engaged with us, right? The primary care physician practices are engaging with us, which we never actually experience in our health home model. So it's very, very inspiring and motivating, and really excited to see where this is gonna go and the networks that we're gonna create and the collaboration between health plans, between government, CBOs, and then a network, like a lead agency that is really bringing these people together at a regional basis.
So when I think about how we're doing, I reflect back on when we were preparing for the implementation of this 1115 waiver. And I attended a ton of these conferences where we had a lot of our colleagues from other states that have already implemented 1115 social care waivers. And some of their biggest recommendations to New York State was, start slow, start with maybe one population, 1 or 2 counties, a couple of services, right? And New York said, thanks for the advice, but we don't have the luxury of time, so we're just gonna go full throttle with all populations, all counties, et cetera. So given that, here we are 4 or 5 months in, I think we all are extremely proud of the implementation successes so far. We probably all are exactly where we thought we would be, knowing that we had to go full throttle here. So I think kudos to everyone who's been working on this, and same thing, I really am excited for what's ahead. We have a lot more work to do, so.
And building on what Caroline just sort of laid out, I think it's important to provide additional context and perspective. Like, we're doing this when the world is on fire, right? And the urgency and the needs and the compounding effects of everything that's going on will place even more pressure on the needs of addressing the underlying drivers of inequities. And so I think back to, when we were looking to have the healthcare delivery system incorporate technology into their systems and implement EHRs. They had decades to do it, and they had millions of dollars. And I would argue that the social service sector isn't any less complicated than the healthcare delivery, maybe even more so, right? And so, I really tip my hat off to Zach and Amie for making this sound like a cakewalk, because it's not. They have huge challenges ahead. But one of the things that I think we have really lifting us in New York is the way in which we as a community really come together, and the way in which I think CBOs have been hungry for this opportunity. And it's not like, they started planning a year ago, 2 years ago. This has been in the ecosystem for years, right? And so it's an opportunity to implement on those visions of, wouldn't it be great if we did X, Y, and Z? The other thing I will say is that, part of the intent of the waiver is certainly to strengthen the CBOs and to strengthen their positionality relative to the healthcare delivery system and put them on more equal footing. And that's really important as we think about the degree to which the underlying drivers contribute to healthcare expenditures. And I think that this is certainly something that we will be paying close attention to. The other thing that I will say is that in strengthening the CBOs, I think we need to be realistic that in some circumstances, strengthening CBOs will mean that CBOs will grow as the standalone entities that they currently are. But in other situations, it may make more sense for them to merge with others that are doing similar work in their communities, and that in so doing, we all win. And so I'm excited for what comes forward and how we as the Health Equity Regional Organization can support the work.
Thank you, Dr. Barbot. I think we'll delve into sustainability in the current context in a little bit, but one question before we go there, which is, what are some specific learnings and developments that we think are really going to inform health plans, public health? And I think Dr. Barbot started talking a little bit about these changes that might be coming, but in your implementation to date, in your work and partnerships to date, what are some lessons that are going to transcend just the waiver time period, but really understanding how this integration works, what's needed?
I think some of the most important learnings here will be the big theory of change question, which is, if we are able to provide these services through this network for these key populations, will we see improved engagement in preventive care, better management of chronic conditions, and less turning to the hospital for support? And that question is a slightly different question for each population that we're talking about. And from a CBO perspective, it's really, does this new Medicaid resource, can it be effectively integrated with public resources that they receive? Can it be effectively integrated with philanthropic resources that they receive? Does it support the right kind of workforce for them for a sustainable business model? And I'll give maternal health as an example because we have a lot of background and knowledge there. Combining, there's an evidence-based program called home visiting, which works with you throughout your pregnancy and until your child is 3 years or 5 years old. And it's got an incredible impact on maternal health outcomes and child health outcomes. We've been struggling with getting access to these home visiting programs right for many decades. We can now integrate prenatal health risk screening with social needs screening, and we can combine home visiting models, the doula payment models through Medicaid, the CHW, community health worker funding through Medicaid, with these new enhanced services through the social care network. Will that make a maternal and child health-oriented, community-based organization stronger and more successful in their mission? That's the kind of question that we're really asking about and the learnings that we're really going for here.
I want to build on that a little bit because I agree with you, Zach. I think probably one of the biggest things that I'd be looking for coming out of this is really whether this model, this sort of hub model, is going to work for CBOs. I think as health plans, we have been administering and providing on a smaller scale these social care programs. But the big question is, how do you bring this to larger scale, leveraging local community-based organizations, local people, local staff, and this model is really meant to drive involvement and capacity at the local CBO level. So I think we'll really be looking at what was learned here about how to bolster and stabilize those local resources.
So I'll add to that from the perspective of the Health Equity Regional Organization. And you'll notice that I say the full name because I just have an aversion to saying HERO. I think that just sets you up for just not good stuff. But anyway, so the Health Equity Regional Organization, I think the learnings, Tanya, will be focused on the data that's going to be generated through the screens by the SCNs. And so for the first time, all of these data points will be filtered through to our organization, and we'll be able to work with SCNs to help draw insights on how are they doing in terms of meeting the needs that are coming through from the screenings, and how does that fall into the overall needs that we're seeing from a public health perspective, and are we moving the needle, small as that movement might be, in the right direction, not only to meet the needs of individuals, but then collectively to meet the needs of communities. And I think that Additionally, what we're excited about in terms of the learnings is how can we draw insights about the successes and the challenges of one SCN in comparison to another SCN, and how can we bring them together to do joint learning so that, again, as a system, we grow stronger. I think then the last thing I would say in terms of the learnings are part of the requirements, if you will, for the Health Equity Regional Organization is to then take these learnings at the ground level, at the systems level, and wrap around with Medicaid data to help make recommendations about how these models can help inform future value-based payment models, right? So that's the long-term goal. It's really ambitious, but I think that it will get New York to fly with data as opposed to flying blind on what's working and what's not working.
So I'll take a little bit of a micro version, and the learnings that the HVCC team needs to do on a daily basis is really looking at how to pivot and support our network, right? Because we're building and flying blind, right? Yes, we get data on a daily basis with our IT platforms, but how do we support our CBOs to do the integration, right? So if you are primarily a substance use provider, how then do we integrate the social care needs into your model, into your workflow, right? Or if you primarily serve your food pantry, how can we get you comfortable in having conversations around the whole health of a person, right? So those are some of our micro learnings since we've launched in January. And the kinds of conversations and work groups that we've had to develop, right? So we created like a nutrition work group to help our nutrition providers to really think about the integration of other parts of the healthcare system because it's so fragmented, right? How do we bring the social care navigators together to become more versed in areas that they may not be versed in, right? And this we've drawn on from our health home experience of being a lead of 400 care managers in the Hudson Valley area, and the level of knowledge that these care managers have had to have, because the health home model is a model that looks at care coordination across, right? So somebody with serious mental illness and co-occurring disorders and have chronic medical conditions and are homeless. Our health home care managers help them navigate that system, right? And so the learnings that we had from that experience, we've applied here, and really working with our providers on the ground to pivot in a time that has caused a lot of uneasiness, that we're not secure anymore, and really provide that support to them that we're gonna get through this together. We have such an opportunity to make a dent over the next 2 years with data, with resources, that let's really come together, figure this out, so that we have a better New York, right? Because this is getting implemented across New York State. It's not just the city, or it's not just upstate. We have the privilege here and the opportunity to see something phenomenal across New York State happen.
So I think you have a sense, there's just an immense amount of work effort, infrastructure, resources being put in, facilitated by the waiver. But we are operating in a time of federal funding shifting, sustainability being kind of a top of mind issue, because we don't want this to go away, all this tremendous work to go away in '27. So I have some specific sustainability factors that each of you may be thinking about. And I just wanted to ask each of you that question. So Dr. Barbot, starting with you, how do you think the private sector will participate longer term in this transformation?
So I think there are three sort of things that come to mind when I think about that question. One is in terms of the sustainability. I was recently at a Milken Institute Future of Health event, and I attended a panel on food insecurity. And one of the things that struck me was that the panel was composed of a number of different people, but that there was someone from Kaiser representing the healthcare delivery system. There was someone from Kroger's grocery store representing the business community. And there was someone from who was in leadership of the Farm Growers Association. I might be messing that up, but representing another aspect of the business community. And so when we think about the sustainability of something like this, I think that business has an opportunity to walk alongside CBOs and other advocates that are talking and screaming about the importance of innovation within Medicaid, right? And so having those diverse voices, I think business very much needs to think of themselves in that arena. The second thing that comes to mind in terms of what role business will play in the future, I think of more a little bit cautionary, right? And I think about the example of how technology in telemental health has made a huge difference in increasing the access of individuals to mental health services. But at the same time, it's created challenges when you think about the degree to which the workforce has been cannibalized from brick and mortar providers, right? And so thinking about the business community moving forward, how to more closely partner with brick and mortar providers so that it's a win-win-win for both CBOs, patients, as well as business. The third thing that I will say is that I think this is an incredible opportunity for business to play a role in sustainability, right? One of the things that my hope is that the the Health Equity Regional Organization will be able to do is through the data and through our collaborations with the social care networks, we'll be able to identify promising practices that are demonstrating improved outcomes and help to take those to scale across the state, right? Because I think long-term, I don't know about the benefits of letting 1,000 flowers bloom. I think this is an opportunity to really drill down on what works, what either helps to reduce medical loss, in expenditures, or actually ends up saving money. And so I think business will play an important role in helping with that perspective.
And an important stakeholder for that and a future sustainability factors, managed care. And so Caroline, what's the value proposition you would see being critical coming out of this for managed care?
Yeah, that's a great question. So I think first and foremost, it's obviously the outcomes, right? So it's, did this model impact, utilization, behavior, and health outcomes ultimately. But when you kind of unpack that a little bit, I think the really, really critical piece that health plans will be looking at is whether this specific model worked, right? So did the operations work? Was this, after the, demonstration period, is this a well-oiled machine that can interact with our members in a way that the members feel good about? We use the term member abrasion in health plans, and that sort of means, to annoy a member or maybe, rub them the wrong way. So we don't want to do that. We want a model that is going to really engage with members, pull them in, provide them with access to this benefit in a way that feels right for them. So I think the biggest thing that we'll be looking at as we move through this implementation and process is this model working? Is this really what should be, how we deliver this benefit in the long term? And that is no small undertaking, but I think if this model is, honed through this demonstration period to a point where we really do feel like it's operating effectively, I believe the outcomes will follow. But I think that's the key critical piece that's going to be important, is that all of the operational pieces that it takes to make this work.
Very true, and member abrasion is, we haven't spoken enough about the members, but that's a very critical aspect of it. The flip side is really the integration that now has to take place for whole person care in a whole new way. And so, Amie, my question to you is, how do we integrate with existing programs? How do we not create situations for our CBO partners that maybe haven't braided funding before, and how do we think about that integration?
That's $1 million question, Tanya. So I think in the Hudson Valley area, what the basis of how we came to where we are was always a whole person approach. Our core network really worked with people with serious mental illness and co-occurring disorders. However, on the health home side, we had federally qualified health centers and our hospitals, right? So we had the entire continuum of care. We had the community-based organizations, we had most of our substance use and mental health providers part of our network, and then we had, we did our outreach to our government partners, because our government partners, they have existing resources that people could get referred to, right? And then bringing in our physicians and hospitals. With that ecosystem where the community is at the core, as opposed to a large provider system being the core of the ecosystem, it's the member and the community-based organizations that are at the core of our model in the Hudson Valley area, right? So we always put the member first, and then the second we put the frontline providers. And so how can we make that model sustainable and make the lives of our social care, whatever title you want to use for a care coordinator, right? Social care navigator, care manager, care coordinator. These individuals are the ones that are working with the members who have been marginalized. And I was just on a call yesterday planning for another conference, and one of my colleagues said, these frontline providers, these social care navigators, community health workers, care managers, they're like firefighters. When everybody's running away, they go in and they help navigate this fragmented system, right? If you think about it, you have your mental health system, you have your substance use system, you have your social service system, then you have your medical system. I had 2 parents I had to take care of. I'm in the healthcare field. My sister has a doctorate in the healthcare field. We needed help. We could not help our parents. Very similar story to Nima. Very, very similar story. And so sustainability is going to rely on this cross-sector collaboration in a co-design methodology where we're advancing equity. And equity still has to remain at the forefront, because a large provider should not get paid more than a CBO that's doing similar work, right? So we have to move forward in a sustainability model where there's equity in payment, cross-collaboration, and co-design methodology, because then we will all buy in, and we are all coming together as a village to create the sustainability plan and moving forward.
All right, to wrap up, Zach, 'cause we have 1 minute. I think a key tenet of this waiver is to make CBOs more robust. And one, sustainability factor will be ability to participate in value-based payments, which we talked about a little bit on this panel. So how do you see CBOs becoming more robust as a result of this to participate in VBP efficiently, I think is the key question here.
Community-based organizations don't stop at the limit of their mandate from their funder. They do what needs to be done to help the person in front of them and their neighborhood and their community. And so they are doing a tremendous amount of work off the side of their desk. And now we are able to bring resources to make them more effective in having that impact on an individual's life. And Caroline and I talk almost on a weekly basis about why mom doesn't make her postpartum visit. Maybe she has maternal depression. Maybe she's overwhelmed with trying to learn how to breastfeed her baby. Maybe she's trying to do odd jobs so she can purchase a crib or diapers. And organization that supports mom, a CBO that supports mom, needs to have a healthcare resource, a government grant, a corporate partner to provide the diapers, and the social care networks can help bring that together, not just for one creative organization that Caroline's already been working with in a small community for 5 years, but bringing that to scale in New York City with a health plan as our partner. And I think that's how it's sustained.
Excellent. Well, thank you all for making time and sharing your insights from the front lines. I really appreciate your time today. And I think we are moving on to our next item. Thank you.